and who I am. So, good afternoon, everyone. Thank you for tuning in on a 4 p.m. session. So today we're looking at simulation teaching. So I'm Nabila. I am the simulation coordinator for the faculty. I work under the Center for Health Science Education. So a lot of what we're going through over the next hour is very education founded, and also just challenging to sort of take you out of a comfort zone. And that's the main aim. So I'm a clinical associate by profession, and I've been teaching clinical associates for the last 8 years or so, and joined simulation this year. But I've been using simulation in my teaching for the last 2 to 3 years. So today the goal is to have a lot of people come over to the simulation side of things and use it a lot more. I'm gonna switch camera off just for bandwidth, and we're just going to get started. So the topic for today is hoping to take people through how simulation can contribute to developing reflective practitioners. And something we'll look into as well is why do we feel that it's important to have a reflective practitioner? And we'll look at how simulation can enhance teaching of that and the development of this type of professional. Okay, so when we talk clinical teaching, we are looking at a variety of methods and ways and professions that do clinical teaching in different forms. And I've tried to incorporate a lot of different professions into this slide, just so that everyone has a sense of how simulation can be incorporated in every health professions education or health science education. We're looking at, bedside teaching in a hospital healthcare setting in the top left corner. We are looking at a variety of disciplines in the middle, where you've got your occupational therapist, your physiotherapist on the right, your pharmacist, your doctor, your nurse, your administrator that has the patient in, and your clinical associate who treats the patient in conjunction with the team. You have dentists that do clinical teaching in their own ways and forms. You've got the radiographers, the radiologists who also come into the fold. And within each aspect and within each scenario and each teaching session, we've got different objectives, and we teach in a certain way so that we can meet those objectives. And something I would push everyone to think about and reflect on throughout the session is, why do we feel there's a need to not solely teach in the hospital setting? And I think you can type it in the chat, or if you would like to, voice out. What do you think are some of our major concerns with teaching in a hospital, clinic, community health center? I'll give like 30 seconds just for people to type it in the chat, or you can raise your hand just to give an indication of why do you think it's important that we teach in the hospitals, and what are the concerns that we have with that? I see a hand. Ripolo. I hope I'm pronouncing your name correctly. Please go ahead.
Thank you. It's Diapollo. Thank you so much for this. For us, it's hospital staff shortage and the available hospitals or availability of hospitals that are closer to vets. There's a shortage of those. So it's human resources and transport.
Okay, definitely. Yeah, I think transport is so important when you're thinking about it. Student numbers, resources. Abibi is putting in the chat, experiential learning would be a pro. Students can learn in action and at the bedside. What would be a major concern of having students around the bedside? Anything that comes to your mind? Okay, fast-paced environment, a distraction. Anything else? Okay, so for me, this picture kind of sums it up. Where we have been treating patients, and I think, in the previous um, professional learning session, Matthew and I were speaking about simulated patients and real patients. And this picture kind of summarizes how we've been treating real patients in health science education. And for the most part, we've been seeing patients as a commodity. And we've been seeing patients as we've got so many patients in the South African healthcare setting, students might as well learn from them. We've got a variety of cases and a variety of opportunity to learn, so they can be in the healthcare setting and being in that space. But I put to you the ethical concerns around the safety of patients and how we treat human life when they are at their most vulnerable, which is in a hospital. And we take a group of 10 students around this bedside, and we don't fully, and in different areas, there are people who uphold this, but in a lot of our settings, it's very difficult to keep up with upholding patient dignity, with involving the patient and making the patient feel very safe, instead of just using them as, oh, they can learn how to do an IV line on a real patient, or they can learn how to examine this patient on a real patient. And I think this is, for me, where the concept of simulation comes in. It provides this safety net for students to practice and to develop their skills, but also in the larger scheme of things in community, we're keeping patients safe because we're sending students out who would have gone through a simulation approach that enhances their skills. So before we go into what simulation is, how we're going to do it, I'm going to get you to do just a mini task for me. So I'm going to place the link in the chat if people's phones can't scan the barcode. So there's a barcode on the screen. When you scan this barcode, it's going to take you to a shared Google Drive. This Google Drive has some resources I thought people might find relevant after the session. But the document I do want you to open up, and the document we're going to engage with, is the Word document that has a table in it, and it asks you to put in learning outcomes. So I'm going to paste the link to the document in the chat space. Okay, and essentially what I want us to do just for the next 3 minutes is think of one skill that you teach. This doesn't have to be a clinical skill. This can be a communication skill. This can be an ethics skill. It can be anything you want, just a skill that you teach students. And we're only going to fill out the left-sided column for now. I just want you to write out in one of the lines one learning outcome for that skill. I'll give you an example. If we want to teach a student how to measure the patient's pulse, a learning outcome could be the student needs to perform the skill of feeling the pulse, of documenting, how to document a pulse, or how to describe a pulse. So that type of objective. I hope I'm making sense. If I'm not, please just shout. Okay, so we've got breaking bad news, lumbar puncture, working as a team. Okay, performing an ENT exam. Just going to give us maybe 1 more minute. People are still thinking, then I'll move us along. Okay, we've got patient-specific history interviews. Okay, I think we've got a nice group to work with. You can add more because we are going to come back to this document in about 10 minutes. So if you're still thinking, you can continue and then we'll come back to this. And there's a reason I wanted us to think about learning outcomes broadly before we go to a learning outcome for a simulation. So now we're looking at how can simulation contribute to the development of reflective, collaborative practitioners? And in order to answer this question, we need to understand what simulation is. So this is the only slide that has this amount of words in it. And that's just for people who are fairly new to simulation and prefer to see the definition, but I will talk through it. Essentially, simulation is identified as an activity or a task that produces an experience for an individual without going through a real life event. So a lot of times, or initially, it was pilots who used simulation or used simulation the most. And only in the last few years has this come into health science education. And how it's come into health science education was role playing. We've all used simulated patients or standardized patients previously. We can use simulation for clinical scenarios, for procedures. And we do this in inpatient scenarios, complete resuscitation examples. And the aim of it is to provide a structured, step-by-step scenario so that students can reflect on it afterwards. And what this does, and it does this through what we call experiential learning theory, it allows a student to be immersed in a hospital setting or an OPD setting or a theater setting, depending how we develop it and how we design the sim lab. And it allows the student to be immersed in the clinical scenario without fear of harming the patient, without fear of the patient being vulnerable and not fully cooperating, although of course you can simulate an uncooperative patient if that's the objective. And the main aim is that the student assesses and manages the patient or achieves the learning objective without intervention or communication from the facilitator. Because the facilitator's role is more important in the debrief than the simulated scenario. The simulation is meant to have the student go through the clinical scenario or the clinical picture and then reflect and debrief afterwards. And this is how they develop their critical thinking, clinical reasoning, and judgment. Because they're going to document what they do during the clinical scenario. And then at the end, the facilitator guides the student through a reflection or reflective process and asks, what did you do? Why did you do this? Consider what would have happened had you done this. And the nice thing about simulation is the facilitator can control the various factors and manipulate factors as needed. And I'll explain this once we get to what the sim lab does. So the entire simulation outline has a pre-briefing, a simulated scenario, and then a debriefing. And the importance of a pre-briefing in simulation is to allow the student to be aware of their surroundings. So you take the student to the actual simulated room and you show them, this is where you can find the resuscitation trolley. This is where you can find any items or equipment you need to help you in the setting. So once the student starts in the scenario, they're not fumbling and they're not confused as to what's expected of them. In the pre-briefing, you'll give the student clear objectives in that in this skill or in the scenario, this is what we're going to do, without giving away too much of core content, but at least allow the student to know this is an emergency scenario. This is an OPD or an internal medicine setting. Or you tell the student in this session, you don't know what you're going to get, so you need to be prepared with how to manage a cardiovascular patient or a respiratory patient or a pediatric patient. And those objectives need to be quite defined and set in the beginning. Then you've got the actual simulated scenario. And we have templates designed from the SimLab to help with this process. And what these templates do, it allows the facilitator or the person who's designing the simulation to actually think very well about how they want the scenario to play out. And you start from the time the student enters. What clinical picture do you want to give to the student? Do you want to say this is an unconscious patient? Do you want to say this is a pediatric patient, or a patient presenting with the mother, or an aggressive patient, or whatever it might be? And then you go step by step into saying, step one, student must identify 1, 2, 3. Then the intervention you expect the student to do needs to be documented. Then you need to document how the simulation must change once the student does those interventions. So it's a very thought out approach. And the reason it's this thought out is because with simulation, we have various technologies we use that allow us to manipulate the simulation. And I'm going to explain that now. Then we have the debriefing. The debriefing is not done while the students are standing or, when you're about to leave. The debriefing is actually planned time for the student. So when the student enters, they need to know that once the session is done, you will have a 20 to 30-minute debriefing session. And in simulation, the most learning takes place in the debriefing. And in the SimLab, we set out the debriefing area so that the students can be comfortable, so that they can sit and actually reflect properly and comfortably without this rush of needing to leave because the session is over. Essentially, the SimLab is student-centered. It's a safe learning environment. We like to believe we are innovative, and we try to be as innovative as possible. We have been encouraging collaboration. So a lot of you will be hearing from me within the next year about collaborative simulations. And we are around to help the facilitator and the educator design a session that's meaningful and authentic for the student. And that's the goal. The student needs to learn in an authentic environment to best serve the community, to be fit for purpose. And what that purpose is defined by the educator or the community. Slide froze. Oh, sorry. Okay. So now we get to the fun stuff and a lot of what makes my job quite exciting. Sims and their toys. So we've got various types of simulations that we run in the lab, and I'm going to talk through each of them. So we've got high fidelity simulation or medium fidelity simulation. What this means, and I've put the definition of fidelity at the bottom, just for people who are unfamiliar with what fidelity is. Essentially, we're talking about how lifelike and how real the simulation is. And with a high fidelity simulation, we use mannequins or equipment such as SimMan 3G or Super Tori. Now, SimMan 3G, and I'll show you a picture of him in upcoming slides, is an adult life-size mannequin who connects via Wi-Fi through our laptop. The laptop controls SimMan's features. Now, SimMan has amazing features. SimMan has breath sounds, lung sounds, heart sounds, abdominal sounds that can be changed. Abnormalities can be added throughout the scenario so that it's as real as possible. So if a student gives a certain drug and we want the heart rate to go up, we can do that in real time. If we want the patient to crash, we can do that because SimMan's connected to the monitors and the alarms will go up. SimMan can be intubated. We can have pupil constriction and dilation to light, and we can mimic and change that. We can have minor seizures, so he just like vibrates a little bit. When you drop his stats, there's a blue light that goes up in his mouth. He can be catheterized. So SIMMAN is what we call a high fidelity mannequin. And we've done high fidelity emergency medicine resuscitation with him, but we've also done an aesthetic simulation. We've done internal medicine simulation where we might have wanted a pneumonia of an unconscious patient. The physiotherapists use him quite a lot in their ICU simulation, where they have to do physio techniques on a ventilated ICU patient. So he can't be used for history taking. There is a feature where if you're sitting in the observation room, he can be connected to a mic where we've talked through SIMMAN. I have not tried it. The feature doesn't always work very well. But there is this thing called Alex AI. We've yet to purchase it, but Alex AI is an artificial intelligence patient communicator, and he can be used for history taking. What we've done in high fidelity simulation with a task trainer is what we call hybrid simulation. Now, hybrid simulation is where you use a mannequin or a task trainer, such as a lumbar puncture mannequin or an airway mannequin, together with a standardized patient. And we've had students take a history on the patient, examine the patient, and when they need to do the procedure, we bring the equipment or the item close, then they talk to the actual standardized patient and run through the procedure. It makes it as real as can be. Then you have standardized patient or simulated patient-based learning, where we'd have an internal medicine ward scenario, and we do simulated ward sessions, where we set up the sim lab to look like a ward, and we bring in SPs, and the students then take a history. We give a laptop with examination findings, so when they do the exam, we play sounds or we show them a picture, and then they'll have to assess and manage the patient as though they were doing a ward round. We've yet to have virtual reality. So virtual reality is putting a student in a computerized version of a healthcare setting. Those of you who've seen those Samsung goggles and things, that's essentially virtual reality. A lot of the gamers out there would know virtual reality and augmented reality. Then we've got flat screen simulation. Flat screen simulation is something I've used now and then, where you've got an app that allows the student to manage a patient or see a patient through a computer. There's an app called Full Code for emergency medicine that works out really nicely. We've yet to have virtual reality clinical software tailored for the South African setting. So that is an area of interest. Okay, so this is the VidSim lab, or a room in the VidSim lab. What you're seeing on the left is a facilitator who is talking to the students who are in the actual SIMMAN's room. The laptop that she's got, and you can see in the picture on the right, is the laptop that controls SIMMAN's findings. The point of this is that the students need to feel that they are in that environment by themselves, or as close to it as possible. And the facilitator will only intervene if they need a finding or the student is really clueless about something. This was actually a trauma surgery simulation where the trauma surgeons, the registrars, and MOs came to do a trauma sim. And what you're seeing on SIMMAN's pelvis is pelvic immobilization that they've done. Then we've got different ways in which we can set up SIMMAN, the simulation lab. So on the left, we've done group counseling sessions for a mental health patient, for example. On the top right is our simulated ward where we put SPs on the beds. Bottom left, a close-up of the simulated ward with a progress note and equipment they might need. And then on the bottom right is a close-up of SIMMAN. Now, SIMMAN also has a feature that allows you to put up ECGs and X-rays on the computer when the student requests it. So we can upload results for you And when the student requests it, we'll put it up. We've also done a lot of neonate training. So we'll have students run through the basics of neonate resuscitation or infant CPR, and then we take them through a simulated scenario of the neonatal resus. So a scaffolded approach to simulation. On the right, we've done a pediatric emergency simulation for the emergency medicine registrars. Then we did something really fun. So this is a hybrid simulation, and we did this for the family medicine registrars a few months back, where they had to do an OSCE by video, and we had an SP, we had a part-time task trainer, and the students or the registrars were expected to do the thorough consultation with the SP, then move to the task trainer and do the procedure. So in this case, it was a lumbar puncture, and then come back to the patient and do patient education post-procedure. This is an example of the flat screen simulation and the full code app. So the student would go through the actual scenario, but virtually. Okay, so maybe before we get to the outcomes, now that you've seen the advantages and the things we do in simulation, are there any questions, any burning things that I haven't clarified or described appropriately for simulation? Okay, so what we're going to do now is we've written the learning outcome for a skill that you have done. What I'd like you to do now is take that same skill and write the learning outcome for the simulation of that skill. So for example, when we're teaching breaking bad news, you'd teach students this through a skill sheet or a lecture or maybe a simulated patient. My challenge to you now is, now that you're going to teach it in a simulated scenario, how does the objective change? So from performing a lumbar puncture, how does that objective change in a simulated scenario? Or what's added to the objective when you're doing it through simulation? I hope that makes sense. You can keep adding to it. If anyone is confused, please feel free to ask. I can see the chat space as well if you want to type anything in.
Hi Nabila and Atlanta here. Yeah, just a little bit more clarity on the other half. What is very simple to put in the learning outcome. It's actually teaching ENT today.
Okay, so for example, let's say you taught ENT exam, and the objective was what objective? The learning outcome was that the student at the end of the session must perform the complete ENT exam, right? Now, in a simulation, you might want to give the student a patient that has an ENT complaint, and your objective might be the student now needs to identify an ENT complaint, or maybe the student must now integrate and then actually formulate an assessment of an ENT case. Does that make sense?
So it's more applied because, I mean, of the simulation technology. I see. Thank you.
And I mean, even for something like teamwork, we are saying we're going to teach students, this is how the roles in the different teams are. But maybe we want students to now actually work in a team, and your objective or your learning outcome might change a little bit. There might be more reflection in there. Oh, the link to the document. I'm resending it now. At least it also says anonymous, so no one's feeling on the spot that we all reading what you're typing. And I mean, you can even think for point number one in Breaking Bad News, we're saying after a failed research, they must learn how to explain the situation to the family. You can even have them actually do the research. And the objective isn't their technique in the research, the objective is the Breaking Bad News. Or the objective is how did they uphold patient dignity when the patient demised. And those are things to think about when you are thinking of using simulation for various elements of clinical teaching, communication teaching, collaborative teamwork teaching. Such great verbs when you're actually talking about learning objectives. Explore, recognize, describe. For interested people in this folder that you all do have access to, and I'll send the link again, there is a document on how to construct objectives for simulation. So that when you come into the Sim Lab, we do help you with that, but we will give access to good resources as well. Okay, so I'll give us just another minute as people wrap up their learning outcomes. So sexual and reproductive health, definitely. I think there were cases we were looking at around how do we teach ethics through simulation. And I mean, a lot of it could be counseling or, so having students just observe an ethical conundrum. And it's so different giving them that ethical case on paper versus having them be in the actual setting and then needing to take some action or think through a framework to use for making a decision or taking action. Okay. So if I may ask anyone who'd like to contribute to the discussion, in looking at the list of learning outcomes for skill versus a learning outcome for simulation, can anyone pick up or reflect on what the big difference is for a skill versus a simulation when you're constructing a learning objective? Anyway?
I think you have to engage with something. You can't just do the skill. You need to be using, you know, the available space, the environment, or you must be using the available mannequin to its full potential. So you have to be using something in order to meet that outcome.
Definitely. Mervyn, I see your hand.
Thanks. You've been very stimulating. I need to ask a question just relating initially to breaking bad news. The process we all understand, and we try and teach and we try and explain, and intellectually our students appreciate that. How do we simulate the response of the patient or the family to dealing with that bad news? And how do we teach our students to cope with their own reactions, A, to the problem, and B, to the response of the recipient of these bad tidings? You know, it's such an intense personal issue that I find it difficult that we can even create AI to deal with these emotional responses.
Yeah,
both patient and personal. Thanks.
Thanks, Mervyn. I think that's such an important point. And we often actually don't consider the after effects. So we'll teach the student in that space, and I mean simulation as well. But I think the after thing that you just mentioned, how do we teach students how to cope with it? And I think for me, that's why the debrief and simulation is so important, because that's where the student would have gone through the process of breaking that bad news, hopefully we would have had a good enough standardized patient. And in one of our simulated wards, we had a standardized patient who cried with every single student. And I think, you know, we're looking at collaborations with the faculty of, the School of Drama, the arts and drama students, because I think they can bring such value for our health sciences students in making it as real as possible, in mimicking that real life reaction or response, so that when we get to the debrief session, it becomes so much more meaningful, because then the student actually does feel like it wasn't just a fake patient. And I think those 2 points are something we should definitely look into, because we all use standardized patients for counseling and breaking bad news. But it comes back to, I think, our conversations in 2 weeks ago, where the training of our SPs are becoming even more important. Where if we want to protect our patients out there, we need to train inside so much more vigorously. But to answer the second part, the debrief is the most important in helping the student, one, cope with the process of what they've just done, but also their feelings, their emotions, developing this resilience in or through simulation. I hope I've answered. Maybe I've just given more work to
No,
everyone.
it does answer in terms of the logic behind it. And intellectually, the student probably would understand because they've seen the circumstances. But to actually deal with one's own emotions, to try and be calm, to try and be consoling, and then have to walk away from that and appreciate in the scenario you've just given, where you've tried to do a recess which has failed, how do we teach our students how to deal with that? Because that can be emotionally quite devastating for the practitioner.
Definitely. So we've done that. I've simulated this not last year, I think once last year and once the year before as well, where I had groups of students come in groups of 5, and we used a high fidelity mannequin, and they ran through their thought process was, this is a recess, and that is all they thought. The objective of this is to resuscitate the patient. And they recessed, and the way we set the scenario up was, no matter what they did, 20 minutes of CPR or whatever it might be, that patient was not going to be revived. And after 20 minutes or so, we said, station over, we're done. Let's debrief. And all of them immediately went to, what did we do wrong? Why did the patient not revive? And I said, the objective of this was for the patient to demise. Now tell me, what's the thought process around not a failed research, but a research that wasn't successful? And that changed their thinking a lot. So we can do that. And then in the debrief, you reshift their focus to dealing with the loss of a patient. And that's been quite intriguing to watch. I think 2 years ago, we also simulated, I think pre-COVID actually, we simulated a research that wasn't successful, and a week later, so we told students to document all their interventions, document all of whatever was done and what didn't happen. And a week later, we had a discussion with the students to say, now we're going to do an M&M, and we're going to go through what happened. Because in the debrief after the research, we've dealt with a lot of the reflections, and now we're going to deal with the clinical picture of the patient. So I think separating that is important. We tend to go to a lot of the clinical skill technique, and I think what you're mentioning around how the students dealing with it is extremely important. That simulation can definitely help with that.
Thank you for that. My only question would be, I understand the process and I appreciate the purpose of the process. Has anybody ever counseled these students after they've actually been in a real life event to see what their responses have been?
I can speak from my experience, but I'll allow others to share theirs as well. So I have previously have counseled quite a number of students who've dealt with that. And then when I struggled, I then brought in student support services. I don't know if others have other reflections or points to share. Okay, I'm not seeing hands. So I think that, so we have, I know I personally have, I know other course coordinators would most likely have counseled those students. But we also do have a really strong student support service at PVT that does work in conjunction with various course coordinators and clinical lecturers to help students deal with that. But I do think it's something that's quite important for us to be aware of, and we can't always get it right. But I think we can provide students with quite a number of tools to help them develop that resilience. So we do have 10 minutes left. I'm just going to try and wrap us up a little bit before just taking the last 5 minutes of burning questions. So I think exactly what people have been saying. When you're teaching a skill, The main difference is that you're so focused on the technique of the skill, on the student being competent to perform that skill. And when we say bring that into a simulation, it now becomes more than just the skill itself. It becomes about, is the student able to apply that skill into a real life setting, into a patient scenario? If we don't tell them at this station, you're going to perform a lumbar puncture, and we just tell them, go and see this patient and do the management plan or investigation needed for this patient, or assess this patient as needed, in whatever way it might be. I mean, this could be a physiotherapy student that's going to assess a patient who's got a sport injury, or an OT student who's going to assess a patient with a cognitive disability. If we have really good standardized patients, we don't tell the student that's what they do, but they go in and they learn from the entire integrated experience. And that's what simulation brings, that conventional skills teaching doesn't always bring. Simulation then also allows you to measure and actually check what students are doing. And in a hospital setting, at bedside teaching, we don't fully have the time to reflect with students. We don't have the time to have structured deeply. And this is why we are sort of, advocating a lot for the simulation lab. So I thank you everyone for just putting in your objectives, and I hope it gave you a little bit of a mind shift in, one, how to write objectives, but also how you can now bring in simulation to enhance meeting different objectives. Okay, so
Sure.
yes, I hear a voice.
That was an acclamation. Sorry.
I thought I heard Cook's voice. Could be wrong. Okay, so concluding thoughts, and I put this to everyone out there. I think I've motivated enough, so people might be scared to tell me no, but should simulation be incorporated into the various clinical training? And if so, I would just like one person or two people to give me an idea of how you want to do this. And then best believe I will send you an email to make it happen. So maybe think about the how. You can message me on Teams afterwards, email me. I'm almost always in the office opposite the simulation lab, so come and chat. And I'm very, very keen to have people, pilot simulations even, or observe other simulations that we have. And then the last food for thought point is interprofessional simulation, and how can we incorporate interprofessional simulation into our curricula so that we all become pioneers of it, but at the same time, we all see the value in it. And I think this is where my last point comes in that we need champions of simulation. We need champions of teamwork. We need champions of collaborative simulation, so that we all not coming into the sim lab, for an hour and then leaving, but actually developing this community of practice so that we know each other. And I think, COVID has now in the last month allowed us to have that network and have those people and have those face-to-face sessions and interactions, which become so valuable. And okay, so 5 minutes left. Closing point, welcome to my world. I love what I do. So come and talk to me, and then, come and have fun in the sim lab. That's most of what we do. Any questions, anything anyone wants to ask? It could be to me, it could be to the team. Anything else at all? Kokok, I note your hand.
Just a big thanks, Nabila, for a great talk, a great presentation, and I hear your inputs around the capacity in the skills lab with an eye on what we can reproduce on the extended academic platform and at what stage, because there must be a trade-off for between, of course, expense and frequency of use and I guess basic usefulness for the core curriculum at an undergraduate level, for example, to try to align all of those things to decide how we can replicate a clinical skills simulation competencies on the extended platform. I look forward to engaging around that at some point. But thank you very much.
Yes, definitely. I think I had spoken to a few people who told me that there are some mannequins and capacities at certain hospitals. So within the next few months, I do want to make trips to those hospitals to see how it's utilized. Because I think if we've already got some equipment out there, all that's needed is capacity and potentially faculty development workshops so people can understand how to use it, and then we integrate it into people's day-to-day teaching. A view simulation medical education and how some labs would look like. So I think in an ideal world, I would see simulation integrated into every single curricula in the faculty. But more than that, I would love to have simulation be the space for networking, collaboration. And when people come into the sim lab, power dynamics and hierarchies go out of the window and people work together to treat a patient, to manage a patient, so that when they're out there, they become the role models that we actually need. And I know I sound so idealistic, but I do believe with teamwork and a lot of champions, I do think it can happen. So keep on the lookout for a lot of my emails requesting to collaborate. And I think some labs are going to change the face of health science education. We've got virtual reality in addition to just your high fidelity. You've got the opportunity to have a student in the sim lab, and in our sim lab, the sim man's room has a camera where it can project to the TV screens in the debriefing area. So even if a student's not immersed in the simulation, they can give very real-time constructive feedback to students. And then there's no reason we can't put that on a Teams meeting and have people in the external areas also come in and give input and feedback. Ideally, I also see us, going out into the platforms to run simulations often, or to teach people how to run simulations. But I do fully believe that simulation can create a new cadre of reflective practitioners who see the value in teamwork, the value in different professions, have a culture of respect and dignity towards patients, and are just safer for the majority of our vulnerable populations and communities out there. And with that, I think I end this session. Thank you everyone for joining, the contributions, the feedback. I know it's a late afternoon, but I appreciate the time. I'm in the sim lab. Come and chat whenever needed. Thank you. Have a great afternoon.
Thank you so much.